Hello, everyone. My name is Charlotte Barber. I am the Gender and Mental Wellbeing Lead at WHISE, and I'd like to welcome you to the recording of the Your Mind on Menopause webinar that was held on Tuesday, the 14th of November. Now, you're in for a fantastic conversation, so I won't keep you too long. I just have two important points before we get into the recording. The first one is for you to please take about 30 seconds to a minute to scan this QR code and complete the pre-session survey. So this is super important for our monitoring and evaluation to ensure that we are achieving the learning outcomes that we set out to do, and we really do value your feedback in the pre-session survey. It's what we then go and compare your post-session survey answers to look at sort of changes in levels of knowledge, understanding, and confidence. So please pause the video now, scan the QR code, and complete the survey. Excellent. Okay. And the second part, really importantly, is that we just like to give a content warning that there are some that of mental ill health, and just to sort of preface that this conversation, there are some complex and potentially distressing topics that are discussed by way of the interaction between menopause and mental ill health. So we just want to remind you that support is always available. Both Lifeline and Beyond Blue are two mental health helplines that are open 24 hours a day, 7 days a week. We've got a few other points on the slide as well, but please take care of yourselves and take breaks as you need, and reach out to these fantastic services if appropriate for you. So I'd like to start by acknowledging that I'm on the unceded lands of the Bunurong people of the Kulin Nation, and pay my respects to elders past and present. Just to give a very brief overview of women's health in the Southeast, if this is your first time or your 10th time attending an event with us, welcome. We are a primary prevention agency that advocate for the health and wellbeing of women in the Southern Metropolitan region of Melbourne, and we have 4 key priorities. So we aim to enhance gender equity really in everything we do, by working directly with communities and organisations. We have a fantastic team that do a lot of work directly with migrant and refugee communities in this space and in lots of other spaces. We work to prevent gender-based violence, improve sexual and reproductive health, and promote women's mental wellbeing. And this webinar is a joint action item between the Sexual and Reproductive Health Portfolio and the more newly formed Mental Wellbeing Portfolio. And this is probably a good time to introduce myself. I am Charlotte Barber. I'm the Gender and Mental Wellbeing Lead at WHISE, and I'm joined by Tanoni, who will introduce herself in a moment, and Laura Riccardi in the background, who is the Sexual and Reproductive Health Lead. So to give an overview of this evening and to introduce our wonderful panelists, we will first hear from Associate Professor Caroline Gurvich, who is a neuropsychologist and Deputy Director of the Her Centre at Monash University. We will then hear from Kathy Helmarick, who is a nurse practitioner at Peninsula Health, who'll give more clinical reflections on menopause. And then we'll hear from Kerry Strickland, who is a member of the WHISE Menopause Working Group and the manager of Aboriginal Health Community at Monash Health. And she'll be bringing in more of a lived experience perspective to this conversation. Please feel free to ask questions through the Q&A throughout, because we've got a Q&A session at the end of this, and then we also have a resource to distribute that is linked in the post-session survey. So please stick around until the end, where you'll receive the post-session survey, and once you've completed that, again, it's a very brief survey, you'll have access to a resource that we have put together around 10 commonly asked questions about menopause. Okay, so I will pass over to Tanoni.
Thank you, Charlotte. I'm Tanoni. I'm a Health Promotion Officer in Sexual and Reproductive Health at Women's Health in the Southeast. And just to give you a little bit of an overview of the menopause work that WHISE has done to date. So in September of last year, we ran a menopause information webinar called Hot Topic with key knowledge experts from the Epworth Hospital, the Victorian Women's Trust and the Women's Spirit Project. So this was attended by 150 people, and it really highlighted for us that there's a shortage of information and support for people experiencing menopause and perimenopause. So we wanted to build on this momentum to do more work to address the gap in menopause health promotion. So in November of last year, WHISE initiated a menopause working group with stakeholders from diverse sectors and organisations and women with lived experience of perimenopause and menopause who meet bi-monthly. So we consulted with this working group to create a case study examining workplaces that have implemented policies to support menopausal employees. And this was published in October of this year. You can find it on our website if you're interested. And we've also been working with Peninsula Health, Monash Health Community and Women's Health Loddon Mallee to deliver community-based information sessions on perimenopause and menopause. So these sessions were also called Hot Topic, and we delivered 19 of those to over 240 participants from June to September this year. And the evaluation data showed a really positive increase in people's knowledge of menopause symptoms, diagnosis, management strategies, and improved their confidence to seek support from healthcare professionals and to speak to their family and their workplaces about their experiences and what they need. This year, WHISE also produced a series of videos on lived experiences of menopause, looking at symptoms, healthcare, and workplace impacts. And among the people interviewed is Kerry Strickland from Monash Health, who's a member of our menopause working group and who will also speak with us tonight. So after the webinar, please feel free to check out these short videos, and you'll find the links in the menopause resource list that Charlotte mentioned, which we'll offer at the end of the session. We've also recently applied for funding so that we can continue developing work in this space, so stay tuned. So now, if I can just invite Charlotte to stop the current slideshow and our next speaker to start setting up the shared screen while I introduce. So our next speaker is Associate Professor Caroline Gurbich, who is a clinical neuropsychologist. She's the Deputy Director of the Her Centre Australia at Monash University and Head of the Cognition and Hormones Group. Caroline has a research interest in the neuropsychology of women's mental health, particularly in understanding how hormones influence cognitive function. Caroline's research combines neuropsychological assessments with eye movement research to clearly characterise cognition. Caroline has over 120 publications that have ultimately contributed to a better understanding of how biological factors influence symptoms and cognition in mental health and mental illness. Welcome, Caroline.
Thank you very much, and thank you for inviting me to speak to everyone tonight. So I will be speaking a bit about brain health and mental well-being during perimenopause, and particularly focusing on my area of interest, which is brain fog. And for people who don't know, a neuropsychologist is a branch of psychology that focuses on brain behavior relationships. And particularly as neuropsychologists, we're interested in thinking skills in people's cognition. So that's why this concept of brain fog is of interest to me. So this is what I'm going to cover in the next 20 minutes. I'm going to talk a little bit about mood during menopause or perimenopause and cognition, the impacts of cognitive changes. A common question that people ask me is, how can I tell the difference between menopausal brain fog and dementia? If we have time, I'll talk a little bit about what causes these cognitive changes. And then I wanted to finish on more of a practical note of what can help women maximize cognition and maximize brain health during and well-being during this phase of their lives. So for people who aren't aware of definitions. So menopause is a period of life that's defined 12 months following the final menstrual period. And perimenopause is around the menopause and refers to all the hormone changes that happen in the lead up to that 12 months following the final menstrual period. So because our ovarian follicles diminish over time, our hormone production changes, and we have these fluctuating and eventually declining levels of hormones like estrogen and progesterone, and we have an increase in our hormones called luteinizing hormone and follicle stimulating hormone. So they're the hormones that change during the perimenopausal period. And that perimenopausal time, those hormone changes can span up to 10 years for some women. So it can go on for a long period of time. And about 70% of women will experience some type of symptom during menopause. So some women experience nothing at all. They glide through menopause and it's a non-issue. And then for the other 70%, so the majority of women will experience some degree of symptoms. So perimenopausal depression is referring to depression that can happen during this perimenopausal period. And we know that this time of life is for many women an increased vulnerability for depressive symptoms as well as clinical depression. The data from the Australian Bureau of Statistics shows that women who are aged 50 to 54 have the highest female age-specific suicide rate. So this is quite alarming. It doesn't mean that this is because of menopause, but it means that this higher suicide rate in females coincides with the age that menopause occurs. From research, we know that risk factors for people to develop perimenopausal depression during this time of their life, there's a few identified risk factors. So one is for someone who has a history of being sensitive to times of hormonal fluctuation. So this might be a woman who has experienced depression across the menstrual cycle. So, and that's normally in the premenstrual phase of the menstrual cycle, or postnatal depression. So these women might be more sensitive to, again, the hormone fluctuations that can happen during menopause. People who experience stressful life events, that's another risk factor. If you've been exposed to trauma throughout your life, you might be more sensitive to hormone changes during menopause. Someone who's got a previous history of depression is also more sensitive to or more likely to develop perimenopausal depression. And there's also research showing that people who have negative attitudes toward menopause as they're approaching menopause, this is also a risk factor for developing depression. These are the key symptoms that are identified as perimenopausal depression. And some people think of it as a unique type of depression. It's not exactly the same as a standard major depression, but similar symptoms. So being sad, losing interest and pleasure in things, or for some women, it might not be that. It might be irritability and frustration, anger outbursts out of nowhere, sleep disturbance, sexual disturbance, decreased libido, loss of energy and tiredness. And some of these are other symptoms of menopause, not specifically perimenopausal depression. So now moving on to cognition. Does our thinking skills change during menopause? There's been a bit in the media talking about this idea of brain fog. And the definition of brain fog was actually only published last year. So it was something that really wasn't spoken about, but now it's in the scientific literature, and it's defined as the constellation of cognitive symptoms experienced by women around the menopause, which most frequently manifest in memory and attention difficulties and involve such symptoms as difficulty in coding and recalling words, names, stories, or numbers, difficulty maintaining a train of thought, being distracted easily, forgetting your intentions, so walking into a room and forgetting why you walked into a room, and difficulty switching between tasks. So that's the clinical definition. But what does it kind of actually refer to? So we've done some research to find out from women what their experience of brain fog is. And we used a scale called the Everyday Memory Questionnaire. And this little graph shows women across the menopause transition. So the darker blue group on the left is our premenopausal group. The orange group is the group of women who are perimenopausal. And then the other colors are postmenopausal, different years of postmenopause. So the orange group, the perimenopausal group, show a higher score, so an increase in their everyday memory problems. And the key symptoms that people talked about were the tip of the tongue phenomena, so word retrieval difficulties, and having to check whether you've done something that you should have done. So these are kind of common symptoms, but they seem to peak during menopause or perimenopause. We've also done a bit of work in women who have early surgical menopause. So this group of women had their ovaries removed due to being at high risk of ovarian cancer. And we were interested in finding out what sort of symptoms these women experience, because there's not a lot of research in this space. And 10 out of the 16 women we interviewed experienced brain fog. Nearly all, about half the women, I think it was, experienced mood changes, so irritability, being cross, memory impairments were common. So this idea of brain fog and mood changes can also happen in early surgical menopause. And now we're continuing this research to do more better design research. This was just our first taste to understand from women what their issues were or concerns were. So I just wanted to touch on a little bit of neuropsychology in terms of what happens, how do we think, what is our everyday memory? And there's lots of processes that are involved in the concept or the idea of retrieving information, of using our memory. And the very first step is sensory input. We always have lots of things in our environment that can distract us, and we have to choose what we're going to focus our attention on. Then we have to hold our attention on that piece of information. You put it in our working memory, which is our bit of memory that allows us to hold and manipulate and use information. We have to then encode that information, store it in our brain, and then at a later time, retrieve it. So there's lots of steps that are involved. And what we see in perimenopausal women, even though they feel like they're forgetful and experiencing memory difficulties, when we assess them in a neuropsychological sense, most women don't have an objective change. Now, this doesn't invalidate their experience of brain fog. About 1 in 5 women do have a small change in that perimenopausal time and up to the first year after menopause. But for most women, what we see is that attention, working memory, people get more distracted, have difficulty holding information in their mind, and that plays out to feel like a memory problem, but it's not always that memory is impaired. And I'll come back to this when I talk about the concern that some people have in relation to, is this Alzheimer's disease? It is also thought from the research that this brain fog is likely to be transient. It's likely to be something that happens in that perimenopausal years and resolve in early postmenopausal years. But the impact of these cognitive symptoms, even though they might be mild, even though they might not show this huge objective change, is for about half of the women in this survey that were interviewed, they said poor concentration and poor memory were problematic for work. In this other study, they showed that over 3/4 of women with menopause symptoms self-reported lower workability. It might not be that their actual workability changes, but they feel like they're not as capable. And then this quite alarming figure from the Australian Institute of Superannuation Trustees that has estimated the cost of menopause to be more than $112 billion. So this is because women drop out of the workforce and then lose their superannuation because for whatever reasons they feel like they're not up to it, or it's not working for them to maintain their same place in the workplace. So we need to try and change this. At an individual level, women describe that these brain fog or cognitive impairments really impact their self-esteem. So a lot of women tell me that not being able to think of the right word, not being able to switch or multitask or hold information in their mind makes them feel less able. They can't absorb information in the same way. This sometimes leads to procrastination. People get overwhelmed, and the anxiety can contribute to this. Then people take longer to complete tasks and avoid completing tasks and making decisions. And all of these things can then impact work or hobbies or relationships, even the benefits of therapy if someone wanted to engage in therapy. So while they might be subtle cognitive impairments, for some women, not all women, but for some women, they can have a really big impact. So this is the question I often get asked. How can I tell if this is menopausal brain fog or is it something else? And the 3 key something else that I get is dementia, long COVID, this has come up in very recent years. And also in very recent years, a lot of people are saying, is this ADHD? They're perimenopausal, their thinking skills have changed, and suddenly they're thinking, I think I've got ADHD. So to start off with Alzheimer's disease, just to define what Alzheimer's disease is, it is the most common cause of dementia. It is a progressive neurological condition, and the typical age of onset is 65 years, and the risk increases each year beyond 65. So most perimenopausal women are younger than this. So that's one factor, which means it's probably not Alzheimer's disease. The mild early stage symptoms of Alzheimer's, so forgetting conversations, repeating questions, might be a little bit of overlap, but wandering and getting lost, difficulties with recognizing people, and difficulties communicating, those sorts of symptoms do not happen in relation to perimenopausal brain fog. And it's not progressive. People don't get worse and worse over time. Also, for people who are experiencing brain fog during menopause, it can happen from time to time. And when people really focus and remove distractions, generally they are able to attend and absorb and remember information. Whereas someone with Alzheimer's, even if they try really hard to remember something, 5 minutes later, they cannot remember it. That information is gone and forgotten. And that's a very different clinical picture. But I just wanted to touch on this question, is whether there is a link at all between the experience of menopausal brain fog and Alzheimer's disease, because females do have a greater lifetime risk for developing Alzheimer's disease. And research has also shown that people who have early surgical menopause are at a higher risk for dementia and cognitive decline in later years. We know that menopause from recent research is considered a dynamic neurological transition. So the brain does change during menopause because of all the hormone changes. So while this might be perhaps a time of vulnerability for some females, we don't know this for sure, this is very new emerging research, I think it's also, we can see it as an opportunity to really focus on our cognitive health and our brain health, and really use this time to make sure we're doing everything in our lifestyles to build really good brain health. So the next question that sometimes pops up is this long COVID, is this menopause? There is a higher prevalence of long COVID in females compared to males, and there is an overlap in the symptom presentation. So things like brain fog, fatigue, reduced stamina, poor sleep, muscle pain, depression, same symptoms in both long COVID and in menopause. So my take-home message, there is no very clear way to decipher whether it's menopause or whether it's long COVID. But for women who have had COVID and they think they might have long COVID, they should also discuss with their health practitioner if they are in those perimenopausal years, so 45 to 55, talk to their GP about maybe this is menopause, and maybe some hormone treatments or menopause-related treatments might be really helpful here, and maybe it's not just long COVID or not long COVID at all. So my take home is just to bring that up, because not all GPs and health practitioners think of menopause as being a contributing factor to those symptoms. So the third clinical question I get is, I think I've got ADHD. So ADHD is a neurobehavioral disease that's characterized by either excessive hyperactivity and or inattention and or impulsiveness. It's always been considered a childhood disorder, but now we think that that's not correct, and it's something that it probably develops in childhood but can last into adulthood. And again, there's a lot of symptom overlap. So women who do meet criteria for ADHD talk about difficulties with organization, that working memory, so holding information in their mind, difficulties with focus, difficulties with attention. And these same symptoms could be related to menopause. Again, there's no clear answer. I've spoken to lots of different psychiatrists and psychologists and GPs about this question, and we don't have an answer, and it's something that needs more research. But if you are someone who is question marking both of these things, bring them up and talk to your health practitioners about it, and allow the different options and therapies to be explored. So why do people during perimenopause experience changes in their mood and their thinking skills? So this is just a little series of graphs that shows what happens to our different hormones, the ones I mentioned at the start of the talk, so estrogen and progesterone, and then the luteinizing hormone and follicle stimulating hormone. So this is what happens across the lifespan of females. So you can see the menopause transition has got these rapidly fluctuating levels of estrogen that are also gradually declining. So this is thought to underpin some of the mood and the cognitive symptoms. So I'm just going to really quickly touch on how cognition and mood actually relate to our brains. I'm not going to go into detail here. What I wanted to just highlight is that there's this blue bit at the front of our brain, which is our what we call frontal lobe. And this is a very basic way of thinking about our thinking skills. It's all actually very interconnected, but the front part of our brain is really responsible for the higher level judgment calls, decision-making, focusing our attention. And I just wanted to also draw your attention to the temporal lobe, the green bit, which is where our memories and our emotional regulation center sits. So just the blue bit at the front and the green bit are really relevant to thinking skills and to mood. And the reason I wanted to show you that is now I've got an even more sciencey graph, but what this is showing is just different neurochemical pathways in the brain, and their red triangles are our estrogen receptors. So these bits of the brain respond to estrogen, and then the darker blue circles are the progesterone receptors. So the point of this slide is just to show you that these areas of the brain, the front part, which is that blue part, and the green part, which is the emotional center of the brain, have lots of receptors that respond to these hormones. And so when we have fluctuations in these hormones, our brains might change as a result of this. And also, you might have heard of the dopamine pathway, which is really important for motivation, and serotonin, which is really important for mood. So these pathways also interact with these hormones. So there's the hormone changes, and then there's the other menopause symptoms, which all independently, we all know if we don't sleep well, you can't think clearly, but these can independently impact our thinking skills. All right, so I'm running towards the end of my time, but I really wanted to finish on this positive note of what can help women maximize their cognition. So hormone therapy is something that you can discuss with your health practitioner. I won't talk too much about that, but I just wanted to talk about some really practical tips and reassure anyone who is experiencing brain fog that it's a normal part of menopause. Tell people that it's important to take time to address these concerns and think about how they might impact your life, and validate it, even if you go and get a neuropsychological test and your scores are in the normal range, just to validate that it's still a really important symptom that people might experience. And moving to even more practical tips. The first one is for attention. So to help your attention, it's really important that people try and reduce their mental load so they don't have lots of information floating around their heads. Really actively attend to things. So take the time to do that. You can get rid of distractions. You can use self-talk to reorient yourself onto tasks. Things like mindfulness and meditation are really helpful. Memory, it's really good to use lots of aids. Use diaries, use calendars, use reminders, use post-it notes, whatever helps for you. It's a positive thing to use those external prompts. For the tip of the tongue, which is a really common one, it's good to try not to get too anxious about it. It can happen. If you need to find the right word, just try and describe an alternate word or describe what you're talking about. Use an alternate word, or use prompts like the sound of the word, starting sound of a word rather than the starting letter to try and prompt you. And then to promote more than cognitive health, like brain health and mental health during midlife, during the perimenopause, there is a lot of evidence for all of the things I'm about to mention. So exercise, having a healthy diet. And in terms of diet, the Mediterranean diet is the one that probably has the biggest evidence base. Good sleep. It's an easy one to say, sometimes not always easy to achieve, but again, a lot of evidence for good sleep. Hormone therapy, as I said, important to discuss with your health practitioner. Being socially connected, there's now a lot of evidence talking about the benefits of having a really good supportive social network, so a good excuse to hang out with your friends. And stimulating your mind in whatever way you enjoy. Don't do Sudokus. If you hate them, just do something that you enjoy to keep your mind active. And the last thing is that we often have new research trials and research opportunities through our research centre. I'll put this in the chat, or I'll get someone to put it in the chat, and you can log on and have a look at them. But this is an example of one clinical trial where we're looking at a new hormone treatment for depression in perimenopause. So I'm going to stop there because I think I'm out of time, but thank you very much to everyone I work with, and thank you so much for listening and for inviting me to speak today.
Thank you so much, Caroline. You've given us so much to think about, and I'm sure a lot of what you've covered in terms of symptoms and concerns are really going to resonate with people listening tonight. And I appreciated that you ended on a call to action and some ways that we can relieve some of those worries and look after ourselves and relieve the pressure to love Sudoku if we don't as well. So I'm going to introduce the next speaker, but I'll just invite Kathy to start loading your slides while I do that. Okay, so our next speaker is Kathy Almarek, who's a registered nurse and midwife who's worked at Peninsula Health at Frankston Hospital and in the community health setting for 2 decades. She specialises in women's health as well as sexual and reproductive health, and she recently completed a Master of Advanced Nursing Practice at the University of Melbourne. Kathy works in a variety of settings, including women's services, midwifery, home care, and in the community. Her community role includes a clinical component as well as the provision of sexuality education in both primary and secondary schools. Kathy also provides a regular clinical session at Headspace in Frankston, which incorporates an educative component. And Kathy was also one of the facilitators of our Hot Topic information sessions that we've run the last few months, and we really appreciate her amazing work on that project. Welcome, Kathy.
Oh, thanks very much. Hopefully you can hear me now. Thumbs up for somebody. Thanks, Charlotte. Thanks very much for your talk, Caroline. I learnt lots. And I don't want to go through my presentation in the degree that I was going to, because I don't want it to be repetitive. So what I'd like to do is try and build on Caroline's presentation, which was fantastic, just to talk about how mental health in the clinical setting can be one of those things that is difficult to separate out. And indeed, I don't think it should be separated out. I think, in fact, what happens is that women do need individualised care. And when we think about the specialised fields, sometimes that can narrow down the actual diagnosis of a mental health issue that's related to menopause. So, for example, somebody going to a women's health clinic or seeing a gynecologist, the focus may be more on the biological aspects of their menopause. When women come into the clinic, it's important to give them the time to talk about what they're feeling, and the guidelines around or the template that we hand to women about menopausal symptoms is a really useful tool, because it can actually help to identify mental health issues as well. And as Caroline said, there's certain things that women are experiencing during the perimenopause that can actually exacerbate those mental health issues. For a start, being female, you're more likely to have mental health issues if you've ever experienced postnatal depression. Menopausal depression is more likely in those cases. And when you're comparing women versus men and mental health issues, we know that, and I'm talking about non-binary individuals as well, women are 4 times more likely to have an anxiety disorder. They're 2 to 3 times more likely to have depression as their male counterparts. They're more likely to have eating disorders and post-traumatic stress syndrome as well. So it's really important to think about, okay, the biological differences can be, in fact, underpin or exacerbate mental health issues. And then on top of that, with the decline or change in the hormones, particularly the potent steroids, estrogen and progesterone, during the perimenopause, that can actually cause mental health issues or lead to exacerbation of those. So we know that there's, as Carolyn pointed out, there's lots of estrogen receptors within the brain, and that's something I think as clinicians we can forget about, because we're thinking about the physical symptoms of hot flushes and night sweats and those sorts of things. But actually the brain is impacted as well through perimenopause, because those estrogen receptors in the brain are being deprived of those potent steroid hormones. So the fluctuation in estrogen, progesterone and testosterone, especially estrogen, can affect mood. And a significant new depression or a worsening of depression can occur during that time as well. So we need to individualise care. Sitting down with a woman when she presents for a menopause discussion, or even if she doesn't, she may just present because she wants to talk about the issue of incontinence or a change in the menstrual cycle, which has become irregular or heavy. And she feels as if on further consultation, we realise that perhaps this individual or this person is perimenopausal, and once you start talking and doing an assessment, you find that there's all other sorts of issues that can be bothering her. So when we look at menopause, we need to look at the biological functions, the interaction socially, and the psychological aspects of care as well. Quite often it's a time of life when there are lots of competing demands on women, and it does add to that the stress and anxiety that women are experiencing. And I know, speaking from personal experience, as you age, it is more difficult to have the capability of coping with the demands of work. And of course, as you get more experience, the demands are increased when it's a time that you're trying to balance other things in your life, like young teenage children or older parents. So it's a real juggling act, isn't it? I think I just wanted to move on, unless there's any questions or comments from anybody. Carolyn, if you wanted to add anything to what I've just been talking about. No, keep going. I'm sorry, I've got to. Every now and again there will be calls over the audio, so I'm sorry, I'll just put myself on mute for a couple of seconds. So I thought what I'd do is talk about some of the questions that were asked pre-event. So thanks for sending in those questions. They're really great, but they probably will require a little bit more time to answer. Do you want to put those questions up, Charlotte, or shall I just read them out and answer them?
Yeah, I'm happy if you just read them out and answer them. That's awesome. Thanks, Kathy.
Okay. So HRT, MHT, so we used to call menopause hormone therapy hormone replacement therapy. So now the current trend is to call it MHT. The first question is, if I am currently fit and healthy and going through menopause but choose not to take HRT, will the lack of estrogen have any long-term effect on my overall health? So as we've just heard, the average age of menopause is 51, and about 50% of women don't have really dramatic symptoms. However, we do know that estrogen can mitigate some of the risk factors of things like cardiovascular disease and osteoporosis. So we don't actually prescribe menopause hormone therapy to prevent osteoporosis, but that may change in the future, because we know that the evidence is showing that it's an extremely effective way of preventing osteoporosis. But we do know that the lack of estrogen can impact on our long-term health in those areas. And we also know that, as I mentioned before, there's receptors in the brain but there's receptors, estrogen receptors throughout the whole body. So every part of the body can be affected with by the decline or fluctuation in estrogen and progesterone. If you want to think about your overall health, I'm not necessarily saying that everybody should go out and get menopause hormone therapy, but it's important to talk to your daughters in particular, check with your GP and talk about any of the menopausal issues, or your health practitioner about any of the issues that may be bothering you. Most people who don't have symptoms don't really worry about taking menopause hormone therapy, and maybe that's something that will change as we get more evidence. The second question was, can you tell us why women would choose not to take HRT given the amount of protective factors it offers? So I've already mentioned that your risks of heart attack and stroke are decreased if menopause hormone therapy is prescribed at the right time. But if somebody has other risk factors or comorbidities like hypertension, if they have a weight issue or have high cholesterol, we know that we have to be a little bit more considerate of prescribing and what to prescribe. So there's a big choice of what menopause hormone therapy can be prescribed. So it's really up to you to have that discussion with your health practitioner about your options. We also know that there is some protection against bowel cancer as well. That's something that's come out in recent research. So it is really worth considering, particularly if you are symptomatic. Is HRT suitable for someone who previously had estrogen and progesterone positive breast cancer? It's not really, and it's important to know that there's lots of other treatments that are available and may be more suitable, but that's something that a person that has had a positive breast cancer, estrogen receptor positive breast cancer, needs to have a discussion with her oncologist and breast surgeon about. I do have one patient who is using Vagifem, which is a vaginal treatment for her vaginal dryness and some urinary incontinence, and that's really very effective. But I consulted with her oncologist about that, who gave the green light to prescribe. Another question is, what essential vitamins and minerals can reduce what essential vitamins and minerals can reduce through perimenopause and beyond that affect our mental health? So I think what the question is what can we actually, what diet or what vitamin supplements could help with the perimenopause? So Carolyn's already mentioned the Mediterranean diet, but everything in moderation. So things like, it's recommended that you have 4 serves of dairy per day to help with bone health. But keep in mind that you may be wanting to monitor your weight and cholesterol levels. So if that's the case, perhaps a calcium supplement might be a better option. Be aware of fat in the diet. So when somebody comes into the service and wants to commence menopause hormone therapy, we always do the screening test first. So we may talk about making sure that they've had breast screening, making sure that they've had a cervical screening test, and we always check blood pressure and screen for cholesterol, etc., so that we've got a baseline finding and we know that it's safe to prescribe menopause hormone therapy or something else. So often we find that women do have high cholesterol than it should be, and so we've got to think about how you would modify your diet. But having a Mediterranean diet hasn't got as much of the animal fats in it, so trying to have the lean meats and proteins really important, because it also helps to suppress appetite. Oily fish every week, eggs and cheese, and making sure that you eat all the colours of the rainbow, basically. So all your fruit and veggies in every colour. The next question was, and this is, must be really difficult for this young woman. I'm only 34 menopausal due to chemotherapy and tamoxifen. I'm desperate for some effective relief from the sexual dysfunction and the deep depressive mood swings, but keep hitting dead ends. I feel panicked that I am expected to live like this for the rest of my life. I guess my question is, where do I go to for help? Oncologists and GP are doing what they can, but I'm still miserable and desperate. So we know that there are some medications that can help with mood, and the SSRIs or the SNRIs can be helpful. It's important, of course, when you're on those sorts of medications, just to be mindful of weight. And I think it's really important for this person to speak to a menopause specialist, and that menopause specialist, might be found through Jean Howes or this Australasian Menopause Society, somebody that has a special interest in this field and can help, can liaise with the oncologist and breast surgeon to get the help that you need. I'm really sorry that you're having that experience. Another great question was, do you have any advice for women in their late 30s who are possibly approaching perimenopause on how best they can prepare their body and mind for this phase? Which is a really good question. And again, it's all about staying healthy. If you're a smoker, stop. I know it's not that easy. Alcohol, we know there's a link with alcohol intake and breast cancer, for instance. We know that there's a link with being overweight and breast cancer. So it's a really great question. If you're in your late 30s and you have some of those vices, it's a time now to action those, and staying healthy with your Mediterranean diet, exercise, and thinking about your mental health and what can you do for yourself that really helps you to relax and have some time for you, particularly when you're busy with family and or older adult parents. So, and some of the things that we've talked about already are things like mindfulness, relaxation activities, even things like joining a book club, which is what I've done, because I think it's a little bit, it makes you think about something else other than your current situation. It's a distraction, but it's also meets the demand of being in a social circle, which is always lovely. And so there's just a few things that hopefully you've got time to do and spend a bit of time on yourself. I think that's about all I've got to say, Charlotte, unless anyone's got any more questions.
Thank you so much, Kathy. We really appreciate your clinical insights and looking at those pre-questions that people submitted before the event. And if you have any questions, keep them coming. Please submit them to the Q&A at the bottom of the screen, and we'll have a big Q&A with all three speakers at the end. But that's throughout for any of the speakers. So thanks again. I might ask our third speaker to put her slides up while I introduce her. So next we'll hear from Kerry Strickland, who is a proud Wadi woman from the Darawal Nation, the First Nations people from the Illawarra region in New South Wales. She's a registered nurse with a passion for achieving positive outcomes for Aboriginal and Torres Strait Islander families and children. Kerry's nursing career has been focused on Aboriginal early years, and she's currently working at Monash Health as the manager of Aboriginal Health Community. Kerry is currently on her journey with perimenopause after being diagnosed in August last year. Kerry is still trying to find a balance with MRT with her specialist and is just trying to be okay with not being okay. And Kerry's also a member of our menopause working group. Thanks, Kerry.
Thank you, and thanks so much for asking me to join us tonight. I am a registered nurse by trade, and I knew nothing about menopause at all. And if I actually think back, I feel I'm 46 years old, and I feel that my journey actually probably started over 6 years ago. Just by smaller things, and then things would just continue happening. And then COVID hit, so I was blaming the COVID fatigue and going through such harsh lockdowns as the reason why I was becoming depressed. So I'd never suffered from depression before, had a previous anxiety when I was a teenager, and pretty much I always said my whole life that I'd live my whole life over again, except for adolescence, whereas I've actually swapped that now. I'll live my whole life through adolescence to not actually go through this at all. So I thought that what I'll do is, instead of talking about the symptoms that, you know, we all know about, that I'll probably discuss mainly how my journey looked and how I got to where I am now. So like we said before, I was diagnosed in August last year. I actually had gone into the doctors thinking that I had hypothyroidism from some of the symptoms. And I walked in to get my results, and yeah, no, sorry, Kerry, you are not, you did not have hypothyroidism. You are actually perimenopausal. I have great trust in my GP. And I had to wait roughly 3 to 4 months to get an appointment with a specialist, because he was actually very open with me and told me that he didn't specialize in menopause and wanted to put me in the care of someone that is well known with menopause. So I then always thank Kathy, and I always bring this story up. I was very lucky to work with Kathy at Peninsula Health. And Kathy and her beautiful work colleague, Robin, actually wanted to meet with me to discuss, I think it was HPV in the Aboriginal community and what that can look like to get the Aboriginal youth kind of more engaged in and getting up to date with the HPV. If it wasn't actually for that meeting that I had, I wouldn't have been able to get out of bed that morning. In my head, we talk about brain fog, and I 100% had it. When I think back to back then, I actually do not feel like I was in my body. I feel like that I was looking over the top of my body. And even when I talk about it now, that's how I still feel I was at that time. I was not, it was horrible. It was the most horrible experience of my life. So poor Kathy and Robin, I turn up for this meeting, did not even think about women, that they work in women's health and that could be menopause as well. And I walked into her office, and I literally was on the ground in the fetal position going, oh my God, I don't know what to do. I had used all my sick leave up with menopause because I wasn't able to function. I was actually extremely lucky that I got redeployed through COVID, and I was actually doing COVID monitoring where I was actually ringing people. So it made it quite flexible as well. And I don't know how I would have coped. So Kathy and Robin were amazing. And we spoke about some of the treatments and what that could look like. I also, the day that I found out that I was perimenopausal, I actually had my blood pressure taken just a couple of minutes after being told this, and was actually sent straight to hospital, to emergency, because my blood pressure was so high. He didn't want to send me home. So I also had that, which I'm now medicated and stable for my blood pressure. So I really, really, really wanted to discuss the weird symptoms of perimenopause that I would never have thought could be it. So the things like the heart palpitations were absolutely horrible. And an interesting too that I had that I really wanted to bring up was itchy ears. So I would literally couldn't scratch to get this itchiness out of my ears, and I never realized that that was a thing. And the other one was as well was I was feeling like I had eaten way too much pineapple. And so my tongue became very funny. And that's actually a thing as well. So I can actually feel when my estrogen levels are dropping, because I get that kind of taste back in my on my tongue as well. Something that I really struggled with is paranoia. I get paranoia really bad, and I actually still do. And memory loss as well. So muscle tensions was another one. I've been seeing an osteo for over 10 years, and it's the same osteo, and she can't believe how tense I can actually be when I go in to see her. So my treatment is I see my specialist once every 6 months now. We're still trying to work out my MRT. And I'm also having to play with things. So I was on 250 by 75. So the 75 was the estrogen and progesterone. And then they put me on one that was called, I was on continuous first, and then they put me on sequel, which meant that there were two different, for the time in your cycle, there were two different strengths. So what I found with that is that actually made my estrogen go down again. So my last appointment 2 weeks ago, my levels were below average. So they've put me back onto the continuous. The reason they actually took me off it was because I was having 3-week bleeds and 1 week off. So we swapped it, and my period did go back to semi-normal, but the mood didn't make up for it. So I've now gone back onto the continuous, and I'm now at week 2 with having my period again. So I think that I'd prefer to have my period than feel like I can't get out of bed. Another thing that I like to explain to people is that I actually don't have children. So I think one of the hardest things was actually to realize that that probably is not going to happen for me. I do speak about how I'm very lucky that I have 2 goddaughters that actually see me as their second mum anyway. And I get to hold lots of Aboriginal babies pretty much every week anyway. So I'm happy with that. With the memory loss, I am now on testosterone as well, which is a cream that you put on the top of your legs. And I also do the Vagifem as well for the vaginal dryness. I've actually gone to my beautician to get my bikini line waxed, and she's told me that she's not going to do it because she's worried that the skin is going to rip off my area, my bikini line. So yeah, I am just about, like I said before, just trying to be okay with not being okay. I remember there was one time that I just woke up in the morning, and I remember I was just staring at the wall. And I don't know if people have experienced this, where you have a dream and you know you can't move and there's nothing, you don't feel anything, you're not happy, you're not sad. And I woke up this one morning and I thought, that's just how I feel, but I actually know that I'm not asleep, and and that I'm not going to wake up for this. And it scared the heck out of me. I nearly rang the CAP team on myself to get picked up. But one of the things that reassured me was that I was actually really lucky that I didn't have any thoughts of self-harm and any suicidal thoughts as well. So I just, again, tried to be okay with not being okay. And my old boss actually sent me a message when I told her, because she was actually really worried about me as well. And when I told her it was bloody menopause, she actually wrote back to me and she said, this is the start of the rest of your life. And once you get over this, you'll have the best time of your life, because you're not going to have those hormones. So I just bloody hope it's going to happen soon, because I'm kind of getting over this perimenopause as well. So yeah, I have 2 patches that I have to wear for my medication, the Vagifem, which is twice a week, that you put internally, the testosterone, which is extremely expensive, and I've actually ran out, so I haven't got any more yet, and I have noticed that the memory loss is kind of coming back as well. So I just really want to let people know that this is my journey. I'm happy to answer anyone's questions if they have any questions for me. I'm very open and a very open platform. But yes, please be mindful that this is my journey, and we've just all got to live with it and just be nice to ourselves the whole time. So, and again, thank you so much for having me.
Thank you so much, Kerry. That's such a beautiful message to finish on, and we really appreciate your openness and honesty in sharing so much of yourself with us. I'm sure a lot of people are really resonating with what you've said.
Thank you.
We might go to some questions that have come through.
Yes, and I will just say, as we start answering the questions, I totally understand if people have to sort of head off, or we will be sending the recording, but we would just appreciate if you could please take a few minutes to complete the post-training survey as you're listening in to the questions. And just a reminder that once you've completed that survey, you'll get a resource of 10 commonly asked questions about menopause, with a resource that has a whole bunch of questions and answers and links to great resources. But I'll pass back over to you, Tin.
Oh, thanks so much, Charlotte. So we might start with a general menopause question that's come through. So someone has asked, hello, can I please ask what age is considered early surgical menopause, i.e. menopause due to hysterectomy?
I'm happy to answer that. So menopause between the age of 40 and 45 is considered early, regardless whether it's medical, surgical, that's considered early. And then if it's natural menopause prior to the age of 40, that's considered premature menopause. Or if it's surgical, then it would be considered early surgical menopause. So either from having your ovaries removed, or if it's medical in terms of perhaps if someone's had cancer therapy, chemotherapy, and it's resulted in a medical menopause.
Thank you, Caroline.
Thanks, Caroline. Okay, we've got a few questions coming through around menopause hormone therapy. So one around what is the right time to start MHT? Kathy, I might give that one to you, please.
Yes, sure. So the right time to start, that's a really great question. As we said, early menopause is between 40 to 45, but if you're having symptoms at that time, it's probably even more important for you to consider menopause hormone therapy for the reasons that we mentioned before, because it has some protective value for cardiovascular disease and bone health in particular. So it depends whether you're symptomatic or not, really. We base our diagnosis of menopause on clinical signs, not on any particular blood test. We would do a blood test if somebody had premature ovarian insufficiency or were going through early menopause before the age of 40. We may do some blood tests then. Otherwise, we base our diagnosis on clinical signs because it's a phase of life. It's not an illness. And that's when the intervention of treatment would come into place.
Thanks, Kathy. And just another follow-up one around MHT is if you start MHT, when do you stop? And if when you do stop, does your body suddenly experience menopause symptoms again?
So I'll start and Carolyn can finish this question if she wants to. So we used to say that, we try and limit the treatment time to 5 years. Now we know that the evidence says, some women experience menopause symptoms for much longer than 5 years. And so most of the time they can be safely treated with menopause hormone therapy. Some women, about a small percentage of women, have menopausal symptoms right up into their 70s and 80s. And depending on their risk factors, some of those women may require menopause hormone therapy later on as well.
I think you've answered that perfectly, Kathy. I don't have anything to add.
Okay, so we have some perimenopause themed questions. The first one is, how long does perimenopause last?
Can take that. So it's really quite individual, and people's hormones can fluctuate, and you can have symptoms for up to 10 years. Some people talk about, or even longer. It's very individual. So I think if you're in the broad age range and you're experiencing some kinds of symptoms that sound like menopause or perimenopause, just chat to your health practitioner about the different options, because I think sometimes even just making that link that it might be menopause is a big deal in a positive way. Just naming it, knowing why you feel anxious or why you feel irritable or why you can't think clearly. So having a reason for that is a really good positive step. And then you can start to think about treatments and management and acceptance, as Kerry kind of talked about as well, which I think is a huge part of it also. So coming back to the question, it's really variable, but I would say 4 to 10 years is probably what the most consistent statistics say.
Thanks, Caroline. And following on from that, another participant asks, how do you know if symptoms are due to perimenopause or an existing health condition, such as chronic migraines?
I can have a go, and Kathy, you can fill the gaps. I would say sometimes you don't know why you're experiencing certain symptoms. There's not, for a lot of things, there's no blood test that can tell you, oh, this is because you've got this, and this is because you've got another underlying health condition. I think in terms of timeline and when things emerge, that is probably a good indicator that it might be hormone related. And in terms of menstrual cycle patterns changing, that can be a good indicator again about timing and what's going on. But I don't really have a clear answer. I don't know whether you've got better insights, Kathy or Kerry.
Yeah, I don't have any better answer at all, Caroline. But what I was going to say is that sometimes with the initiation of menopause hormone therapy, if those symptoms resolve, that can be really quite reassuring that that's the correct diagnosis. The other thing is, I think you mentioned migraines. We are always cautious when women suffer with migraines, particularly if they have any visual aura or disturbance with that. But we find sometimes with menopause hormone therapy, by giving a continuous dose, that can actually mitigate or get rid of the migraines because you're not having those fluctuating hormones.
Thanks so much, Kathy and Caroline. A question that I will direct to you, Kerry, was what does the testosterone cream do?
So I don't know exactly what it does. It probably is a Kathy question more. But I was really struggling with my memory loss. So I was sitting in meetings and not remember being in the meeting or what the meetings were about. And so because I started to feel so much better with myself, I'm not sure if my memory loss got worse or I was just could feel it a little more, so it was more prevalent to me. And so when I had the discussion with my specialist, she just suggested to try the testosterone cream. I've only been on that for 2 months, I think it is. And yeah, I didn't realize how much it was actually helping until I ran out I must be on it longer, actually, probably 6 months maybe that I was on it. Yeah, and I just haven't replaced the script, but it's really expensive. I think it's over $100 for the cream. So, but worth it. Now I know that it's working well. I think that's the other thing as well, is that MRT is quite heavy on the pocket as well, which I think is another really sad thing that as women we have to go through, is spending all this money for things I feel like, that it's just not fair being a female. The patches have also been running out at the moment. So I'm just like, I don't want to go backwards. I'm really scared about it running out all the time. And I'm thinking, and I'm not being sexist here at all, but if this happened to men, it wouldn't happen. They would have the stock readily available. If people realized what we're actually going through and how much we need this treatment. I know that MRT is not for everyone. And I had a lot of people that have told me that they won't do that. And that's great for them. But I just want to say that it has actually saved my life. And I actually don't know where I'd be right now. I've only been on it for a year now. I think it's about a year. And we're still trying to get it right. And I'm still having what I call low days. And it is just about trying to be nice. Just, sometimes just waking up in the morning. I've got one goal, and that's to make my bed and open the blinds every morning, because I struggle waking up in the morning still. But I know that once I get up, I'll feel okay. So I just think we all need to be really nice to each other. And yeah.
Going gently. That's really good advice. Thank you, Kerry. I've got one for either Kathy or Caroline about anxiety. I'm experiencing overwhelm and anxiety, and it's really affected me, such as driving. I simply cannot concentrate and get all anxious. I was always a great driver and independent. This has been going on for over 2 years. Any suggestions or supplements that could help me through this? Oh, sorry, I think you're on mute.
Sorry, I was just going to say, Caroline, would you mind answering?
Sure. So I think for anyone who's experiencing anxiety, even though officially menopausal hormone therapy is not indicated for mood, that's the official clinical guidelines, talk to your health practitioner, talk to people like Kathy, and it can help, and it's really worth exploring those options. So we know our hormones change, and trying to replace some of that or balance some of the hormone fluctuations can go a long way. So that's probably the first thing. And then anxiety can really link to that sense of overwhelm, and they fuel each other. So I think when you become anxious, you can become overwhelmed, and that can make you even more anxious, and it can really wind people up, and you can end up in a really terrible space. So I think breaking down tasks, which is what I guess Kerry was kind of referring to when she's, one goal, keep it really simple. So even for driving, which is, complex, and we go into autopilot normally when we drive, and sometimes when we're anxious and think about things and it's no longer automatic, that can be dangerous. So just breaking it down. So keeping your driving trips short, and turning off the distractions, or having like soft, non-lyrical kind of music that can be a bit more calming, rather than having to divide your attention between, the radio or a conversation. Don't talk on the phone while you're driving, those kinds of things. So just trying to calm yourself, and use, deep breathing into your belly to try and calm and ground you and bring you back in the moment. If you find, particularly if you're in the middle of driving and suddenly you feel panicky or anxious, perhaps pull over, deep breathing, cold water, that kind of thing, just to bring you back into the moment, and then reorient yourself and try again, making sure safety comes first. But bigger picture is talk to someone about it, get some strategies, and see if that's helpful. Trial and error as well. The same strategies aren't going to help everybody, so seeing what's helpful for you as an individual is really important.
Thanks, Caroline. And just on that sort of linking to the anxiety question, but could women have one symptom only during menopause? For example, anxiety or headaches? Yeah, that's a question.
I would say yes, definitely. It's, again, very individual. And while hot flushes, vasomotor, those hot flushes, night sweats are the most common symptoms, you can have a combination of symptoms. You can have one symptom. It's very different for everyone. But yes, you could just have one symptom. I don't know, Kathy or Kerry, if you wanted to add to that.
Well, I was just going to say that maybe there's one really overwhelming symptom, and then once that's sort of dampened down, that maybe other things might, you might realize you're actually suffering from a few other things too that are not going to worry you too much. I did want to acknowledge Kerry, though, because I think that she's extremely brave for presenting today, and she has had a really extreme case of perimenopause and menopausal experience. And so I just wanted to acknowledge you, Kerry, and say, all the best. Everything's going to be okay, because you're doing putting everything in place to make things work. So, and we're here for you.
Thank you. And just so you know, the day that I actually found out that I was perimenopausal, the next day I sat in a WHISE committee meeting where it was brought up that we were going to start doing this as well. And I was just like, oh my goodness, everything's just aligning for me. And I could see that there is a light at the end of this tunnel. And yeah, I've never really gone through anything. Like, I've had a fantastic life, and then to kind of hit this. But no, Kathy and Robin, her work colleague, I see them quite regularly out in community, and they're always a strength for us as well. So thank you.
Oh, thank you, Kerry and Kathy. We appreciate all three of you being here today and sharing so much with us. We have a question about IUDs. So how to diagnose menopause if you have an IUD and so no periods. Not sure who'd prefer to take that one.
So that's another good question. We know that if you have a Mirena IUD, which is something that can be used as part of your menopause hormone therapy, if that's inserted at the age of 45, you can keep that IUD until 55 quite safely. Now, often that will reduce the amount of menstrual bleeding you have by up to 80%, and about 2 or 3 in women in 10 don't get periods at all. And it doesn't really matter if they develop it's only got progesterone in it. So if you're going to develop menopausal symptoms, you will. And if you're not getting periods, that's not the only way we're going to be able to tell that you're menopausal. I hope that makes sense. Maybe Caroline might want to add to that. So in other words, you could develop hot flushes and so forth, but not be getting any periods.
I don't have anything to add. I think that was clear, hopefully. I thought it was clear.
Thanks, Kathy. A question around regulations. Does Australia follow the NICE guidelines for UK, or is there another set of regulations here for GPs?
Caroline, do you want to comment on that? Or
I'm happy for you to, Kathy.
Yes, so the NICE guidelines are aligned with the Australasian Menopause Society guidelines, and they're the guidelines that we follow.
Oh, great, Tim, go for it. I was just about to say calcium. Go.
Thank you, Kathy. So the next question is about supplements. So someone has asked, I'm confused as I've heard from a doctor that taking calcium supplements can cause kidney stones, and can you recommend any other supplements?
Sorry, I guess the question is around calcium supplementation. I know that can be the case if you're taking a big dose of calcium. I'm not quite sure, though. I don't think I can answer that question clearly. I hope you can, Carolyn.
Sorry, no, I'm not a medical practitioner, so I'm not really aware of what. Yeah, sorry, no, I can't.
I will say the first question in the resource, if you've done the post survey, is a link in the Australasian Menopause Society to menopause specialized GPs. They're probably going to be a great place to go. And also there are some we've put some specific articles in around nutrition, but definitely good to go and speak to an accredited practicing dietitian as well for nutrition, very specific nutrition related questions. I think we just had a question come through about the difference between MHT and the contraception pill, if someone wants to answer that. And I would just recommend in the last we'll probably have time for another 1 or 2 questions if anyone wants to get one through before we wrap up.
Okay. I was just thinking about, sorry, the calcium question. Obviously, the more calcium you can get from your diet, and if we've got those links with the nutritional guidelines, that would be helpful. Then it's going to mitigate the risk of getting a kidney stone. So getting back to your next question, which is around what is the difference between menopause hormone therapy and contraception. Menopause hormone therapy is much lower doses of estrogen and progesterone. So that's what is required to reduce the symptoms, and that can be given in various methods as patches and gels, tablets, vaginal creams or pessaries, but they don't act as a contraceptive. So we do recommend that women continue their contraception until, if they menopausal or their last period stops before the age of 50, they need to continue contraception for 2 years. And if it stops at about the age of 50 or 51, they should continue contraception for 1 year. And that's why we do often recommend the Mirena IUD, because it is very low, a very low hormone dose. It mainly acts on the lining of the uterus. But it's over 99% effective over, either 5 or 10 years.
Thank you, Kathy. We've got another one that is probably a good one to ask you as well. Do I still need to have regular pap smears, and are there any other tests I should be asking my doctor to do?
Yes, so the cervical screening test we now have available to us, the self-collect, which we know is just as sensitive as a clinician collect a screening test, and it's done just with a small swab, which I haven't got here in front of me to show you, but it's a small swab that's inserted very much like the COVID swab that we put in our noses, except we don't put it in our noses, we put it into our vagina. And it's done, if the test comes back negative, it can be done 5 yearly. If it comes back positive, then there's a different pathway for care. So that's one test that should be done until the age of 74. Breast screen, that should be done every 2 years until about the same age. And by the way, that can start at the age of 40 through the breast screen program at no cost to women. We tend not to do breast or often mammograms too early because breast tissue is usually quite dense before menopause, and so it's harder to pick up lesions. But if you have a family history of breast cancer, then you should have that test done a little bit earlier. So instead of starting at 45 or 50, perhaps a little bit before that. And bowel screening test should start at 50, and that should be done 2 yearly. And all your blood screening for cholesterol, blood sugars, thyroid function, liver function, renal function, that should all be done before commencing menopause hormone treatment.
Thank you, Kathy. So we might take this as the last question, which is, what is the connection between fibromyalgia and menopause?
You can take it, Kathy, if you were.
You speak, Caroline, if I have anything to add.
Okay, I was just going to talk about that there can be overlap in symptoms rather than kind of a biological link between symptoms, but that there can be an overlap and some of the symptoms can be really similar. And again, it's that question or comment of talking about it and exploring different treatment options and seeing what's most helpful to manage or hopefully treat symptoms. That's all I was going to say about that.
Yes, because we know that during menopause that body aches can be a really profound symptom, and that having estrogen therapy can actually settle those symptoms down. But if you have a diagnosis of fibromyalgia, I'm guessing, or often I would think, that those symptoms are exacerbated by being perimenopausal. So certainly having menopause hormone therapy, it's not going to treat the fibromyalgia, to my knowledge. Sorry, I keep going into the dark. But it certainly will help mitigate any menopausal aches and pains, and that could be helpful.
Excellent. Thank you so much. I'm just going to put the survey in one more time and plug that once you've completed it, you will receive access to the sort of resource we created that has definitely covered a few of these questions and given follow-up resources. So it'll be a great one to go and revisit. And I will say, if you sort of consented for us to sort of email you in the future, you'll definitely be kept up to date with sort of future work in this space, because this is just one part of the plethora of things we are sort of doing in the menopause space. But most importantly, I really would just like to say a big thank you to Caroline, Kathy, and Kerry for just such an insightful discussion, both in your presentations and also just this Q&A session. Thank you so much for watching the recording, everyone. I'm just here to close it off and say, please complete the post-session survey. It'll take about 2 to 3 minutes. And once you've scanned the QR code and completed the survey, you'll have access to, you may have heard me mention it in the recording, but the 10 commonly asked questions about menopause resource. You'll be able to download that once you've completed the post-session survey. So again, thank you so much for watching this recording, and we hope to cross paths soon.